Medicare denied Wegovy, Semaglutide, or Zepbound, Tirzepatide, but the drug may not be the problem. Since July 1st, 2026, the Medicare GLP-1 Bridge gives eligible people with Part D drug coverage a $50 monthly copay. That $50 copay depends on 5 gates: coverage, pathway, clinical rules, product, and paperwork. These create 5 denial patterns. Missing one can stop the claim, while another route remains open. The Bridge is a weight management program outside the usual Part D payment system. A central processor handles pharmacy claims and required prior authorization. The pharmacy submits the prescription first. The prescriber then confirms medical use and eligibility. This separate route creates confusion. A Bridge-excluded drug may remain coverable through Part D. A weight loss claim rejected by Part D may still qualify through the Bridge. The denial source determines the next step. Timing matters too. The Bridge runs from July 1st, 2026 through December 31st, 2027. Its $50 copay does not count toward the Part D deductible or yearly out-of-pocket total. Bridge and drug plan coverage use different payment rules. That leads to reason 1: the wrong type of drug coverage. The Bridge requires enrollment in an eligible Part D arrangement. Common qualifying options are a standalone prescription drug plan or many Medicare Advantage plans with prescription coverage. Several less common arrangements do not qualify by themselves. These include private Medicare plans that pay per service, certain cost plans, and all-inclusive elder care programs. Some members qualify if they also carry an eligible standalone Part D plan. The Bridge is separate from the plan, so the plan does not choose whether to participate. However, your enrollment category still controls whether you can enter the program. Medicare Parts A and B alone are not enough. Reason 2 is using the wrong coverage pathway. The Bridge is for weight management when the patient lacks a diagnosis already coverable through Part D. A request tied to a Part D diagnosis must stay with the drug plan. Wegovy may follow Part D when prescribed to reduce heart attack, stroke, or cardiovascular death in adults with established heart disease. Zepbound may follow Part D for moderate to severe obstructive sleep apnea in adults with obesity. Sleep apnea causes repeated breathing pauses during sleep. Type 2 diabetes can also block Bridge eligibility. Another example is metabolic dysfunction-associated steatohepatitis, known as MASH, a serious fatty liver disease with inflammation and scarring. These diagnoses send the coverage request to Part D, even when weight loss remains important. Using a GLP-1 through Part D in 2026 also blocks Bridge coverage. Staying with Part D does not guarantee approval. The plan may still require prior authorization or a formulary exception, which asks it to cover an unlisted drug. Two people can have the same body mass index and request the same brand. One has weight management alone, the other has sleep apnea or diabetes. Their claims cannot follow the same route, even when their medicine and weight look identical. The pathway changes more than eligibility. Bridge coverage uses a fixed $50 copay outside the Part D deductible. Part D follows plan cost sharing and approval rules, changing price and paperwork. When Part D applies, a Bridge application cannot replace the plan's approval process. The plan reviews its covered drug list, medical use rules, and supporting records before deciding the claim. Reason 3 is missing the clinical threshold. The simplest route requires a starting body mass index of at least 35. This measure compares weight with height. This route does not require one of the program's additional listed conditions. A starting body mass index from 30 through 34.9 requires at least one listed condition. These are heart failure with near normal pumping strength, blood pressure still too high, despite 2 medicines, or moderate or worse chronic kidney disease. A starting body mass index from 27 through 29.9 requires a different listed condition. Qualifying examples include prediabetes, a previous heart attack, a previous stroke, or symptomatic peripheral artery disease. Peripheral artery disease means narrowed arteries reduce blood flow, usually to the legs. Symptoms can include walking pain, slow healing wounds, or poor circulation. A body mass index below 27 does not qualify for the bridge. The number that matters is the body mass index at treatment initiation, not the number on today's scale. Someone who started at 37 and later reached 33 can still satisfy the body mass index rule. The medical record must support that earlier value. The blood pressure route requires its own supporting records. Ordinary treated high blood pressure does not satisfy the 30 to 34.9 route unless it meets the program's uncontrolled definition. High cholesterol, arthritis, and general weight concern also do not replace the listed diagnoses. Beyond body mass index and condition rules, 3 more requirements apply. Patients must be at least 18. The prescription must target weight reduction and long-term maintenance. Nutrition planning is required, with activity unless medically inappropriate. Reason 4 is the wrong product form. The bridge includes Wegovy injections and tablets. It includes only the Zepbound quick pen. The single-dose Zepbound pen and single-dose vial are excluded from this program. That difference is easy to miss because every package carries the same brand name. The pharmacy system reads the exact product code. An excluded device can reject even when the patient meets every medical requirement. The wrong device may require a new prescription. The pharmacy cannot bill every Zepbound package as though it were the covered quick pen. The prescriber and pharmacy must match the prescription to the exact product code for an included device. Reason 5 is failed routing, timing, or incomplete paperwork. The pharmacy must first submit a claim through the bridge's billing route and receive a denial. Only then can the prescriber submit the prior authorization request. The pharmacy needs the patient's Medicare number and the bridge's billing route. The prescription also needs a diagnosis code showing obesity and a direction to use the bridge. Missing either item can send the claim to Part D instead. The form requires patient information, product, starting body mass index range, diagnosis answers, and prescriber details. Missing fields can stop review. The prescribing clinician must submit the medical confirmation, so a patient call cannot replace that step. Submitting the form before the pharmacy rejection breaks the required sequence. Resending the same form does not repair that problem. The pharmacy claim must enter the bridge system first, creating the record required for authorization. After any denial, identify where the claim stopped. Ask whether Part D rejected it, the bridge processor rejected it, or authorization never began. Then request the exact reason instead of accepting the broad phrase, "not covered." A Part D denial may require authorization, a formulary exception, or an appeal. A bridge denial needs a different correction. It may involve enrollment, diagnosis routing, starting body mass index evidence, product form, or paperwork sequence. Repeating an unchanged claim usually produces the same denial. Do not switch devices or pay cash before checking the pathway. Match the prescription, diagnosis, starting body mass index, product code, and authorization sequence to the correct system. The 5 reasons are ineligible coverage, the wrong pathway, unmet clinical rules, an excluded product, and failed routing or paperwork. A denial may identify a correctable mismatch, not a final rejection. Correcting that mismatch beats resubmitting blindly. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.